bone. I played rugby for the Austin Huns a couple months ago. I had a traumatic brain injury, cracked my skull. Some of the symptoms, light sensitivity, major pains, headache pains, as well as sounds were really affecting me. It kind of messed me up. I wasn't sure if I was ever going to be able to come back to it. So the doctor didn't really have a treatment plan besides time and rest. So I wanted to find something to get me back to normal faster. On the first treatment, I felt amazing. My headache instantly went away while I was in the chamber. After 5 treatments, my light sensitivity went away. My headaches were gone. After 20, my CAT scans came back normal. The brain waves were great. I'm super excited. I feel amazing. I'm looking forward to what improvements that come to follow.
Every day at Permobile, we are helping families battling disabilities throughout the world. Our company was founded under one belief that every person has a right to independence and mobility, and that idea is as strong today as it's ever been. Our passion goes into building wheelchairs and complex rehabilitation accessories so that every product is customized for every individual's needs. We are so passionate about giving back to organizations such as Team Luke Hope for Minds that in 2017 we started the Permobile Foundation so that individuals can live a life without limitations. The Permobile Foundation helps them by sponsoring fundraising events, by building accessible playgrounds, and by providing donations such as equipment so that these individuals have access to their independence and mobility. Permobile and the Permobile Foundation are honored to partner with Team Luke Hope for Minds in their efforts to support families and children battling brain injury.
Dr. Kaufman's medical training began in Washington, D.C., where he enjoyed 13 years under our nation's capital. While he was a resident there, Dr. Kaufman also focused on advanced spinal surgery techniques and specialized in the care of pediatric patients at the Children's National Medical Center. So following that, he went into his residency training and accepted a clinical fellowship at Nemours Alfred DuPont Hospital for Children in Wilmington, Delaware. During this fellowship, he received extensive training from world-renowned surgeons in the management of scoliosis, complex spine deformities, neuromuscular disorders, skeletal dysplasia, and hip dysplasia. So now he serves as the chief of orthopedic surgery at Dell Children's Medical Center of Central Texas. His clinical practice focuses on the management of spinal disorders in children and adolescents with a special focus on the neuromuscular and brain injury populations. Dr. Kaufman has an academic appointment at the Dell Medical School at the University of Texas at Austin, where he serves as an assistant professor in the Department of Surgery and Perioperative Care. So I will go ahead and introduce Dr. Kaufman himself, a fellow Longhorn. Feel free to come up on stage.
Appreciate it. Thank you. That was a very nice introduction. I appreciate it. So I tell people all the time even when I'm at work, but y'all call me Brian. It's fine. I don't mind. I like when my patients call me Brian. I think it's fun. I had a little bit of stuff on here on the other way, right? Who I am. So I grew up in New Jersey. I am not a native Texan. I'm actually the only one in my close family. My wife was born in Houston, then grew up in Pennsylvania, but both of our kids are Texans. So I'm the odd duck in our family. But I drove myself down the highway down I-95 to D.C. for college, undergrad, and med school. I loved being in D.C. It was a really fun place to grow up. I say I was raised in New Jersey and I grew up in D.C. DuPont is a really fabulous institution. Their system is absolutely wonderful, and it was a true honor and a privilege for me to get to work with those people and still consult with them on a completely regular basis. And then, like everybody else, we moved to Austin because it's a fun place to live, right? So where you can find me, I wear a bunch of different hats. We talked a little bit about the academic stuff. I work for Dell Children's as the chief of orthopedic surgery. I have a voluntary faculty appointment at the university at the medical school. And then I'm part of a private practice. It's an all pediatric orthopedic private practice called Central Texas Pediatric Orthopedics. We've got a bunch of offices around the city. So we've got one, just down the road here, which I'll show you all in a second, but I'm across the street from Dale Children's in Cedar Park, at the hospital itself, and then our brand new office right down the street on 290 is our Southwest office, which is beautiful. I was just there yesterday for the first time. So I think we're all kind of aware of some of the sobering statistics about brain injuries in kids. I don't need to tell you all these slides and tell you numbers, but they occur at an astonishingly high rate. And there's obviously a lot of etiologies that come from brain injuries. I see everybody in that sort of 3 stratifications in that age group in the second bullet point. So the kids under 5, your traumatic brain injury, your highest incidence is from a fall. There's obviously a lot of children with perinatal brain injuries that are affected as well. That is really just traumatic brain injuries that's related to. TBIs are more often falls, still in the adolescent and young child age group, but moving up toward motor vehicle collisions, and then in adolescents, similar to adults, the highest incidence of brain injury comes from motor vehicle collisions. I think the biggest thing is that there is a incredible cost, as you guys are all aware of, not only emotionally, but really financially, to someone living with a brain injury. And we're really good about getting people to survive brain injuries, but the cost that comes afterwards is substantial, and I think that's $60 billion a year annually is what is spent on the medical care of brain injuries. So it is a large problem, as we are all very aware, and something that we try to focus on maximizing function in really the most efficient way. So I can't stand up here as a pediatric orthopedic surgeon and talk about brain injury without talking about cerebral palsy. So your orthopedic and probably neurologic definition of cerebral palsy is a static brain injury that occurs under the age of 2. And the key is that it's a non-progressive brain injury. So your neurodegenerative disorders, while often manifesting in a similar way to a child with cerebral palsy, are not technically cerebral palsy. I tell families all the time with people with rare genetic disorders and chromosome deletion syndromes and everything else that I'm going to say cerebral palsy when I talk about your kid because I need a framework to talk about you. So I often tell the brain injury families as well, I'm going to say cerebral palsy because I've got to draw on a larger pool of research and experience and say, I understand your kid does not necessarily have CP, however, we're going to look at the orthopedic side of things and kind of frame it in that respect. So just know that I recognize that, but I've got to have a framework sometimes to talk to people. What is really difficult for us in our pediatric orthopedic world to understand is why the incidence and the prevalence of cerebral palsy is not decreasing. And there's a bunch of different thought processes there. The main one is that we are really good, again, at perinatal care and having children survive incredible prematurity. So in the 70s, 60s, 70s, 80s, you may have a child who's born at 27 weeks who's going to pass away because we're not able to keep that child alive. But now we're able to keep that child alive and they're going into childhood, into adulthood. So the prevalence of CP is not decreased. That's further confounded by the increase in multiple births. So there's a significantly higher rate of prematurity, which has a higher rate of perinatal brain injury with multiple births. So things like in vitro fertilization are really fantastic for people to start families. That's where my daughter came from. But that also increases your risk of having early births and multiple births, which increases the risk of CP. A bunch of different causes for CP. We talked about congenital, we talked about neonatal, and then postnatal, the most common cause, either near drowning or unfortunately non-accidental trauma, which we see way too much of up the street at Dell. So why do you need me? While a brain injury is often a static event, the musculoskeletal consequences of that brain injury are not static. They are really, by definition, progressive. And you have a whole different type of neurologic presentation of those injuries. You can have spasticity, which is by far and away our most common. You can have flaccidity, which as an orthopedic surgeon is my most simple one to treat sometimes because you're not super stiff. Dystonia is by far and away the hardest one, so dystonia is really challenging, and then ataxia as well. And those musculoskeletal consequences affect everything from seating tolerance to activities of daily living to ambulation to how I see it as how your child interacts with the world. And that's what my job is, to kind of help maximize function and maximize quality of life. When I was up here a couple years ago, I had a slide up here saying that there's really not physical medicine and rehab physicians in Austin, and I'm happy to say I don't have to say that anymore. Dr. Vasquez is our chief of pediatric medicine and rehab at Dell Children's. She comes from Texas Children's with over 10 years of experience in managing a very robust PM&R program there, and we're really excited and fortunate to have her as part of our team. And I also have a wonderful partnership with our whole neurosciences program at Dell Children's now. It's really an honor for them to bring me into their fold and work with people like Dr. Tyler Cabarro, who's our chief of pediatric neurosurgery, who came from Pittsburgh and is taking our neurosurgery program to new heights, and to work with the whole team that Dr. Roach has established in the neurology department. We're very fortunate and blessed right now. And I also want everybody to understand that I'm an orthopedic surgeon, so the surgeon is part of my title, but as a pediatric orthopedic surgeon, know that we really see surgery as a last resort. I was talking to a family with a collarbone fracture, with a clavicle fracture yesterday, and I say this all the time. If you put me in a situation where I can treat you equivalently with surgery or non-surgery with the same functional result, at the end of the day, I'm going to choose non-surgery every single time. Because what's the point of me operating on you if I can't actually make you better? That's the goal of having an operation, is to make you better, not to make your x-ray look better, not to line my pockets, not to make the hospital happy with me. It's to make your kid better and to make their quality of life better. So I thought we'd just kind of go top down, and I'm not going to get too deep in the weeds in like orthopedic terminology. So if I use some word that y'all don't understand, I'll try to model things as well. Just kind of stop me, raise your hand, and say, what are you talking about? So the typical deformities we see in the upper extremity, in the shoulder, we're going to see the arm adducted, as in brought toward the body, so tight against the side, and then internally rotated, so turned in this way. Your forearm will be pronated, so forearms can either supinate, like a bowl of soup, so your hands are facing up toward the air, or pronated is turned down. The wrist is going to be flexed and then ulnarly deviated, so your ulna is towards your pinky side, and then your hands, fingers will be flexed, thumb in your palm. So your typical deformities, which you see on the screen there, the reason that occurs is because the muscles that cause those deformities are more powerful than their countering muscles. So your elbow flexors, your biceps and your brachialis, are way stronger than your triceps, which is really your own elbow extensor. Your wrist flexors, unfortunately, are significantly stronger than your wrist extensors, so you wind up with a contracture with your wrist flexed down. What functionally that leads to is difficulty with reaching, grasping, releasing things, manipulation. That position of that child's hand there, that's not a functional hand. So that's hardly a helper hand. And we talk about making sure that we can maximize function of an upper extremity. Cosmesis is not only the appearance, but I also think of that as the hygiene. It's really difficult to clean in really tightly contracted skin folds that can lead to things like skin breakdown, to superficial skin infections, which can lead to pain. So like every other good person, I don't work on an island. This is my lovely managing partner, Dr. Hilton Gottschalk. So Hilton is a real rarity in the pediatric orthopedic world. He did 2 fellowships because one wasn't good enough for him. So he's a pediatric orthopedic surgeon, and he's also a hand and upper extremity surgeon. So he is our hand guy. He has a really keen interest in the neuromuscular population. And Hilton's going to tell you the same thing, that he doesn't want to operate on you unless he has to. Some of the non-operative things that we look at, physiotherapy, PT is a huge portion of what we do. What we're trying to do is prevent those contractures from occurring in the first place, and that's where bracing comes in. Like Bennett braces for your wrist are really common. But sometimes you do need, or an operation is recommended. I think the operative things, elbow contracture release is really helpful for that flexion. It's a hard operation to get right. Hilton, fortunately, does a lot of them. And Hilton wants to see you early. He doesn't want to see you when you're at that picture that we saw on the last slide, where you're kind of contracted down and you're stuck, because that's hard. It's hard for him to fix that. If you're still flexible, there's a lot of really great tendon transfers that can be done. So this is an illustration of what's called a green transfer. So you take the extensor muscle that goes to your small finger, your extensor carpi ulnaris, your flexor carpi ulnaris, and turn it to your extensor muscles. So what you're doing is taking that powerful muscle that folds your wrist down and making it extend your wrist. So now you go from an overcompensation in the flexion really into like a relatively neutral position. And by bringing your wrist out to neutral, it often brings your fingers out of the palm as well. So sometimes that transfer unmasks finger contractures as well. So then you wind up with like an additional procedure or procedure at the same time to lengthen fingers. But you go from this hand, which is not helpful, to this hand, which can do a ton. Even if you don't have great control over the fingers individually, I can now use that hand to help me grab things, to guide things, to hold things. So it's really, really helpful. And the tendon transfers do a lot better than this, which is a wrist fusion, where you're at an end stage. This is a skeletally mature person. This still has a lot of value. That hand here is not helpful for anything. This hand it's rigid. It's a big giant plate and screws in there, and it's fused together. But again, it's in a functional position, and this doesn't necessarily affect finger function. So these fingers can still function. Hilton does not like doing this. He gets mad at me when I send him somebody who needs this, but that happens. He wants to see we can do the soft tissue stuff because it works a lot better. We see a lot of hip deformity. I think hip deformity is probably the most common thing that gets referred to our pediatric orthopedic office related to spasticity. What happens with your hips is your hip flexors and your hip adductors, so again, the muscles that bring your leg toward the midline, abduction is away from the midline. Your hip adductors are markedly stronger than your hip abductors, and what that causes your hip to kind of be in that scissored position for your legs to be brought across. With time, as children grow, that causes the neck of your femur, so this is your femur, this is your hip socket, the neck of the femur to be more vertical. Well, there's what we call a femoral neck shaft angle. So neck of the femur here, shaft of the femur down here. Normal is like 127 degrees, right? So that's about that angle. This is like 175 degrees. Because that constant pull of the musculature as a child is growing, when they are tight and spastic, the hip becomes more and more vertical. What that leads to is progressive subluxation or coming out of the joint of the hips. This is the same kid. So that's a few years later. So now that hip is not really sitting in the hip socket. That progressive subluxation leads to an eventual dislocation. So that hip that becomes dislocated is now even less likely to move, is even stiffer, and then with time can become painful. So to prevent that, we do this, which is a big operation. But what we're doing is turning the hip socket, the hip back into the hip socket, and recreating a hip socket. You might be sitting there and saying, Brian, why'd you operate on that? This is the left side, right? So why'd you operate on the left side? Because this is a kid who wants to stand up and get in a stander. So to do this, we gotta make your leg shorter. There's no way for me to take this and go to this without losing, that height, right? And it's not, I'm exaggerating, it's like 1 centimeter or 2 centimeters, but we're also protecting this hip. So this hip is now protected, is in the hip socket. I was putting this talk together, and this kid came up because we just took these plates out like 2 weeks ago. So, he had 2 operations, but he now has normal hips. Beautiful range of motion. Parents can get his legs apart. No more dry skin in the groin. No more skin breakdown. No more pain. So he's going to do great. When we don't catch you early, this is what you wind up with. So this is a brain injury kid that I followed for a long time. That's my hardware up there as well from other stuff. I think his x-ray is later on in the slide too. But he unfortunately was 15, 16 when we met. Hip had been dislocated. This is his right side. So this is a hip that's been out for 7, 8 years. I can't put that back in. And this is painful. You can feel it in his butt. And a skinny kid, like most of our neuromuscular kids, you can feel his hip right here. And he's sitting on that all the time. It's causing pressure. It's causing pain. So our only option there is what we call a salvage procedure. So we resect the hip. We take out the pain generator, which is here, and just kind of try to give it space and make it a bumper. This is an okay operation. I do not like doing okay operations. I like doing good operations. And it's okay because I tell people it's like coin flip if this is gonna help or not. I don't know if this is gonna help you. At worst, you're where you are when we started. At best, it doesn't hurt anymore. It does not preclude you from standing or walking to have your hip resected. Again, the hip's not doing anything in the first place. This is a pain relieving operation only, but it's an okay operation. So we don't wanna get to that point. Fortunately, Chris Souter is our hip guru. So Chris is an incredibly smart guy. He's way smarter than me. And Chris really likes hips and really likes our neuromuscular population as well. So we focus really on surveillance being the key. This comes from the Pediatric Orthopedic Society of North America. That's what POSNA is. So this is our hip migration percentage index. It's the amount of the hip that is outside or lateral to the hip socket. And we want to follow that with time with serial x-rays. Recommendation is to get an x-ray every 6 months up until the age of 8. If the hips are fully located, you can go yearly after that. If the hips are not fully located, continue to do every 6 months until the age of 12. My mentor always taught me that if the hips were in at age 12, they're going to be in for the rest of your life. How we manage those hips, initially non-operatively, Botox is a really important component to most of our lower extremity management, and upper extremity as well. Botox is injected usually by a neurologist. The way Botox works is it blocks the presynaptic release of acetylcholine from neuromuscular junctions. That's a really fancy medical mumbo-jumbo way of saying it makes your muscles not contract. So it makes them looser. And the problem with Botox is, think of it like any other drug. Over time, your body gets used to it, and that response gets potentiated, it gets decreased. Think of it like, this is the easiest analogy I give people, think of it like a drug addict. Initially, you need just a little bit of drugs to get high, and then over time, you need more and more and more. Botox is the same thing. Over time, your body doesn't respond to Botox anymore, so we use it as hopefully a time stop or like a gap to getting to me where we're maybe operating on you, or maybe we're doing less operating, ideally soft tissue things like just cutting tendons, and which is really minor operation to just improve range of motion. The big stuff is those x-rays I showed with plates and screws, where sometimes we are left with a goal of doing this big operation, knowing that 10 years from now, that kid's gonna be better for it. There's a hard sell for folks. The knees are the next areas we move down. So the most common deformity we see are flexion contractures, really again from overactivity of your hamstrings as opposed to your quad, to your hip extensors, to your knee extensors. What we measure is the popliteal angle, the angle that your knee makes with a vertical line, depending on how you measure it. Either this is your popliteal angle or this is your popliteal angle. And we get to nerd out and orthopedically argue about which one is right. This one is right, it's this angle, just so you guys know. That leads to functional impairment, mostly crouch gait. So if you have to walk with your knees bent, so I'm walking like this, if I have to walk around like this, it's exhausting, first of all, because normally when we're walking, we're just firing our quads to keep our knees straight. If your knee is straight, then your foot hits and you've got a really rigid resistance against your knee bending. If I can't get my knee straight, then my quads are working for me to try to kick my leg out, but also I've got to use my hip muscles, my butt muscles, because I got to pull myself backwards, and my lower back muscles, otherwise I'm going to fall over, right? So this is exhausting to walk that way. Just try to walk around with your knees bent for a while. It also has difficulty with transfers, so kids are doing like assisted transfers. If you're really contracted, it's hard for people to get them up and move. So Matt does a lot of our sports stuff. He's our knee guy, but Matt does a lot of like big tendon transfers and big reconstructions around the knee. And Souder and Ellington and I, we all sort of operate together when needed. But Matt's our knee guru. So hamstring lengthenings is a simple soft tissue procedure. Posterior capsule releases, that is if your knee is so tight we have to cut the tissue that surrounds the back of the knee, or the big operations or extension osteotomies where we cut the bone to for severe contractures. These are very uncommon. Fortunately, we very rarely do that. Then go down to the foot and the ankle. So another kind of big area that I think from a quality of life perspective, if you have a kid who, your goal is not necessarily independent ambulation, maybe it's not even independent transfers, but just being able to sit upright and be comfortable in a wheelchair, foot positioning plays a huge role. There's a cosmesis that comes from being able to wear shoes. It looks normal if you can wear shoes. It doesn't look normal if you can't wear shoes. So it also is protective. We fortunately live in a climate where it's really relatively mild. I grew up in the Northeast. If you can't wear shoes in the winter, you can't go outside. That's not good. So we want to be able to get the feet into a position where you can find nice shoes to wear and your feet look normal. It's also important because you need that base on a wheelchair on the foot plate so you're not sliding off. If you can't get your feet flat, you've got nothing to prevent you from sliding out, and it becomes really difficult to position somebody in a chair when you don't have a base for their feet in the first place. So that leads, so we talked about gait impairment, skin breakdown, shoes, and then difficulty positioning. Dr. Robert Dana is our foot and ankle guru. I love Dr. Dana. He's a quirky guy. He's real smart. He's been doing foot and ankle for a long time, and he really has a passion for the neuromuscular population as well. I think Robert is probably the epitome of somebody who is going to try everything possible to not operate on you. He really doesn't want to operate on you unless he has to. So we talked about Botox, we talked about PT. I think bracing plays a huge role. So all different kinds of braces. An SMO this one on the right. So that is a supramalleolar orthosis. Your malleoli are those bumps on the outside of your ankle. So this is good to control the coronal plane or the side-to-side motion of your ankle. It doesn't prevent you from pushing your foot down this way. That's where you need a AFO, an ankle foot orthosis, or a ground reaction AFO. The difference between these two is a ground reaction AFO you enter through the back, an AFO you enter through the front. This hard plastic piece in the front in the ground reaction prevents more of that crouch. So for kids who crouch, I love ground reaction AFOs. I'm a huge ground reaction AFO fan. And then our operative management, fortunately, heel cord lengthenings are pretty simple. It's pretty straightforward little procedure, pretty minimal. And then flat foot reconstructions, really if needed as well. A lot of times feet are relatively braceable, and if we can get feet into a good position, we can avoid a big foot surgery. Where my personal passion lies is in spine. I'm a spine surgeon. That's what I really love to do. So I'm spending a little bit more time talking about spine. I'll try to whip through this. So I'll give you all some time for questions as well. So think about your spine as a three-dimensional deformity if you have a scoliosis. So you'll curve from the front in the coronal plane. You will have a loss of your normal architecture from the side, either hyperflexed or underflexed. And then it'll rotate as well. So the rotation is what everybody sees, that rib hump. So anything that is attached to the bones in your spine is going to rotate when your spine is curving. Your ribs are attached to your spine. Your ribs stick up when you have scoliosis. But curves after brain injury are different, right? So we see a lot of hyperkyphosis, so this increased bend at the junction of your thoracic spine to your lumbar spine. Normal is like less than 10, so 84 is very abnormal. And it can cause difficulty with pressure sores, right back here, and pain as well. We also see people who are hyperlordotic, so increased sway in the bottom of your spine. This is a cerebral palsy kid who has back from pump, very lordotic, 112 degrees. Normal lordosis is up to 80 degrees, so that's about 40 degrees more than normal. It is very difficult to sit in a wheelchair when you're sitting like this. Your pelvis is rotated very far forward, so you're kind of this way and then back this way. You see a lot of this posture in spina bifida kids. So if you see a spina bifida kid, they look like that. I think the pelvis is probably the most underappreciated portion of the spine, right? So your spine is attached to your pelvis, spine bone's connected to the hip bone. The rotation and the tilt of your pelvis really affects your seating tolerance. So this young man had a traumatic brain injury, and this is the way he sits. He's got his right side, this is his right side here, way up in the air. That wing of his pelvis is pushing into his ribs. So that is what we call a costopelvic impingement. That's not comfortable. Try to sit on one butt cheek and then shove your other hip up into your ribs. You're not going to be too happy. What we want to see is a obliquity to the pelvis that is under 10 degrees. This at 129, so 90 would be 0, right? So that's almost 40 degrees of pelvic obliquity. It's a very oblique pelvis. So what we do is try to make that better by flattening out the pelvis. It's obviously a big operation, but you go from this pelvis, and that's this line right here, to this pelvis here at 5 degrees. This young man now is able to sit up very balanced and even. Yeah, his spine is still crooked, but I put my hand over the x-rays all the time for families and say, look, your shoulders are even, your pelvis is even. If I look at you, you look even. Your x-ray doesn't matter as much. I can make your spine really straight, but that's a lot of work, and we don't want to do that. Why scoliosis develops in brain injury populations, I would say the exact mechanism is probably unknown. There are a bunch of different theories, but to give you a definitive answer, I wouldn't be able to do that. It's incredibly common in our cerebral palsy population. So this young man was in near drowning from when he was 2, and the pretty severely affected or near drowning kids are often very, very, very spastic. So he had this very large curve measuring nearly 100 degrees when he was 4. He had a magnetic growing rod put in, so this was to not fuse his spine when he was that young. And then this summer, we finished him out and said he got a lot taller, probably got gained about 6 or 8 inches in height, and now he's done, no more spine surgery, nice even spine. He looks beautiful sitting up in his chair. Spinal cord injury has a really high rate of scoliosis. This is a young lady who was unrestrained, rear seat passenger in a car accident, had the spinal cord injury. So this is your spinal cord right here. This kind of black funky looking thing is not good. And then this is spinal cord again. So she had a complete spinal cord injury in her mid-thoracic spine with a fracture as well. So I did this initially to treat her for her fracture. And unfortunately what happened over a period of years is that she turned into this. So the lack of tone and innervation just causes your spine to kind of collapse. So to make her not keeping her sit up nicely again. This was also the summer, so nice and straightened out, and sitting up beautifully in her wheelchair again. I think this is my sort of theory on why scoliosis occurs in the brain injury population. You have this muscle imbalance that leads to asymmetric sitting. We know that the spine accommodates over time to the position that you're in. So like any other bone, there's something called Wolff's Law, that bone grows in response to stress. So if I constantly sit this way, which way am I going to grow? I'm going to grow that way. So we try to do whatever we can to mitigate that abnormal stress on the growth plates with good seating positioning, maybe bracing, something to get you sitting up more straight, and that leads to scoliosis over time. Non-operative management, I think PT is great if you can activate the core strength. That's really good. You really want to strengthen muscles on the outside of the curve, so think of those muscles that are on the convexity as needing to be stronger than the ones on the concavity on the inside. You need a well-molded seat back, so you want that supportive system for seating so you're nice and upright. And then bearing weight, we know, improves bone health. And the hard part is that I get asked about bracing all the time, and I brace a lot of my neuromuscular scoliosis patients with the caveat that I ask families to understand I can't back that up with evidence. That any long-term study or big outcome study you do on bracing and scoliosis is really limited by the fact that no brain injury kid is the same. So for me to kind of try to box in and say, hey, every CP kid needs a brace, every CP kid is, there's no every CP kid, right? So that's not a reasonable way for me to approach it. That being said, like I said, I brace a lot of people. I do not like soft bracing to prevent scoliosis. That's not to say that soft bracing doesn't have a role. I think from a therapy modality standpoint, it's really helpful. So those soft, like strapping bracing systems to use in therapy are great. To use to prevent scoliosis, it's not gonna work, it's not gonna be strong enough. So you can use a rigid brace like this girl is sitting in here, and it may or may not help. I think in a best case scenario, you're delaying the prevention of an eventual scoliosis, which is okay. And surgical treatment, I showed you how much pretty x-rays, the spine's looking really straight. I mean, it's a good surgery. It's probably the most rewarding procedure that I get to do, but it's a big surgery. And I say usually for my threshold of 50 degrees, because what matters to me is not what your x-ray looks like, it's what you look like sitting in your chair if you're a primary sitter, or what you look like when you're standing up, and how is your quality of life affected. So this young man has lots of skin breakdown in the folds and his creases over here. X-ray looks like you're very crooked because that pelvis is super high on this side. You're sitting only on this butt cheek. You got this big old curve at the bottom of your spine. So we want to improve your quality of life and make you sit up nice and straight. So we can take away that obliquity and say, hey, now you're really nice and balanced and sitting up. You don't have that big old crease on the side anymore. There's no skin breakdown. And then the sort of subjective things that we see that are measured are things like improved GI function, improved pulmonary function, improved cardiac function. Those are really difficult things to measure definitively in our neuromuscular population. But that subjective, hey, feeds are so much better, pooping is better, they're happier sitting up. Those things we know, and if we look at quality of life measures over long terms, especially in caregiver quality of life, there is an improvement with seating tolerance. It gets a little bit murky because you still have a kid who's very severely affected, so to say like your overall quality of life for the caregiver is less or is different is hard because you're still a large burden on the caregiver, but I think it's a very effective operation. How we do it, one old big old incision in the back, move the muscles out of the way, release some bones, rods and screws, in the hospital for a few days, and really back to normal a lot faster than you would expect. I've had kids go back to school 2 weeks after surgery, neuromuscular kids go back to school 2 weeks after surgery. I had a family this summer who we did hip reconstructions on, and then her spine this summer, and her mom will tell you that the spine was way easier than the hips, and I tell people that all the time. So this is that kid that had the hip resected before, so there's his hip. This is his spine before, this is his spine after. Sitting up beautifully. Their funny story is that this is a tall kid, he's about 6'3". So they fit in their wheelchair van before surgery, but not 3.5 inches taller after surgery. So his mom got a little mad at me about that one, because I've never had somebody that was too tall to sit in a van before, but when you're 6'3", I guess that's what happens. It's not obviously a thing that ever comes into consideration for me. How do you have success in this? This is one of my big passions. I gave a grand rounds a couple months ago at the university about this. So you have success in neuromuscular spine surgery by not working on an island. I am just one very small part of a very large team of people that help on that day of surgery to get there. And it's not just that day of, it's everything you do beforehand. We have a wonderful partnership with the Comprehensive Care Clinic at Dell Children's, who are all saints of human beings, and Dr. Brahani and her team are wonderful people. What we do is try to medically optimize every kid before surgery. So that means that your nutrition is ideal, your lungs are ideal, your heart is okay, your GI is okay, your neurologist is on board. Everybody's like, hey, we're good to go. We got this kid as good as we can possibly get. And then you got to have a team of people that you're working with in the OR, the same anesthesiologists, the same nurses, the same surgical techs, the same person helping me with the surgery, the same physical therapist afterwards, the same ICU doc. And we have all of that. We've built all of that. And the key is don't be afraid to ask questions. I have only one rule for our families before surgery. You're not allowed to have a question. You can be nervous, you can be worried, you should be, but no questions. You can call me and talk to me on the phone as many times as you need. My documented record for phone conversations before surgery is 12, so that was probably at least 20 with that family, but I'll tell you what, that mom had no questions before surgery, and that was good. I'm just going to show a picture from the side. So in conclusion, I'll try to wrap this up. Obviously, brain injuries affect a lot of kids. Severity of brain injury correlates with the risk of orthopedic pathology. Unfortunately, the more severely affected your brain injury is, the more likely you are to wind up in my office at some point. Early non-operative intervention is really key for the upper and lower extremities. Use things like Botox, use physical therapy, use bracing. Try to prevent that deformity from getting to a point where you need me in the first place. My favorite visit is to say, hey, you look great, you don't need me, come back in a year. That's perfect. Define your treatment goals with your surgeon. So what are you trying to accomplish? Are you trying to make the x-ray look better? Are you trying to just get them into a shoe? Are you trying to be able to sit in a wheelchair? Define that goal and then figure out how you want to get there. And then surgery, when done well, really should be done to improve quality of life. I thank everybody, and I'm happy to take some questions before I get back to those little monsters. Yes, ma'am, what you got? Mm-hmm. So I think monitoring the hips is always a good idea in any kid with a brain injury, especially if there's spasticity. We recommend initial evaluations at age 1, then every 6 months after that if there's spasticity. So it's the downside to a pelvic radiographic x-ray of your hips is basically 0. It is roughly equivalent to like half of a trans-US flight. So like the radiation exposure is pretty minimal. And that's why we do frequent hip screening, because we do shielding, we use digital x-rays, so that radiation exposure is very low. So you have a very, very low risk intervention that can guide treatment. So I would say yes. Yeah. Anybody else? I'm also going to give a nice special shout out to these 3 wonderful, lovely people who are sitting right here. So Logan Jenkins, Molly Clayton, Lucy was Vitek, but I forget now. Gan, there we go. Sorry, Lucy just got married. So this is our sort of orthopedic administrative team at Dell Children's. These 3 people are wonderful. They're here supporting us today. They support me on a daily basis. This is, when not on an island, this is like the foundation of my team, and I'm very, very fortunate and blessed to work with all of them. So they're sitting out there. If you all have questions about our orthopedic program, I'll hang around for a bit as well, and these guys are here all day and happy to answer and help you all out if you need it. Thanks, guys. Happy to take any other questions too. Yeah.